Welcome to EMS Update 2024. I'm Brian Shaw, your host here at Studio 51. And with me today are our guests and friends from UPMC, Cheryl Rickens and Dr. Doshi from the Post-Cardiac Arrest Service. Welcome, both of you.
Thank you for having us.
Yeah, so tell us a little bit about the what you have going on here and the Post-Cardiac Arrest Service.
Yeah, well, thanks, Brian. Thanks to everyone who's around today. We're really blessed at University of Pittsburgh and UPMC to have a post-cardiac arrest service, which is a dedicated 24/7 group of physicians, APPs, nurses, who take care of the cardiac arrest patient after our amazing EMS colleagues get their pulse back and bring them to the hospital.
Exactly.
We see 300 to 400 patients a year, mostly through Presby, but also via telemedicine throughout UPMC. And really focus on those last two links in this chain of survival. I know everyone knows that, but really post-cardiac arrest care and then recovery. That's kind of what we wanted to talk about today, Cheryl and I. And in terms of post-cardiac arrest care, there's a lot that goes on. You all know this, right? We need to get the patient safely to the hospital, keep the pulse, but then we need to resuscitate their brain. We need to figure out why they arrested. We need to make sure they don't arrest again. And then we need to do all the secondary prevention to get them out of the hospital. Things that maybe we don't automatically think about in EMS, about the fact that a third to a half of our patients have mental health sequelae after cardiac arrest, that people have rehab needs, cognitive needs, physical needs. And what we do as our service is really bring all the providers together so that they can get all the care they need in a wraparound. And we're lucky because we get to do it 24/7, 365. There's always somebody on for us who can always help somebody out at any hospital after they have a post-cardiac.
Yeah, it's so interesting. You talk about all the patient's needs and from a psychological standpoint and cognitive. You know, for those of us this morning, our keynote presenter, Rob Hoadley from San Diego, who's a post-cardiac arrest survivor himself, he talked about that in his presentation. Nobody told him. He says, I didn't know what to expect afterward. I didn't realize the PTSD and so forth. So is that something that your division looks at with these patients?
Yeah, absolutely. We know that this happens a lot. It happens with both survivors and co-survivors and the loved ones of the patient. And we know that if you actually tell them about it, it may actually help. Mm-hmm. Preparation is a lot of this, whether that's preparation in mindfulness or preparation in just what the sequela will be. And so what we actually do is we provide people with that roadmap to move forward and seeing what their life's going to be like, because it's a huge change in their life. Mm-hmm. And they really want to know a little bit about what's going to happen.
So, I think back my career and, patients that we resuscitated, we took to the hospital, and kind of the end game at that time was they went to the ICU or the CV ICU and then discharged to home. So how did the post-cardiac arrest service really come about? How did you identify additional needs?
Yeah, great history. And I'm not going to speak too much because I wasn't there. But what we realized as a group of emergency physicians and critical care physicians is that all the work we did in the field doesn't change the outcome unless we do the same amount of work in the hospital. And there wasn't a specialist to do it. So what we decided to do is we wanted to be that specialist and to say, how can we do all the things somebody does? So that may be resuscitating their brain in the ICU and cooling them down and giving them targeted temperature management or other brain resuscitation. It may be planning with the cath lab. And a lot of the work that Cheryl helps with is getting us the EMS strips and the AED strips, because our cardiologists want those. They want to be able to see what actually happened in the field and decide on a treatment plan. Mm-hmm. But then sometimes they need someone to help kickstart it and say, oh yeah, you didn't see the EMS strip, let's get it free. Yeah. Cardiologists, they don't live in the EMS space often. They don't know how to do that. And then we need to get them out of the ICU to the floor and deal with all these other kind of things that we're talking about and get a rehab plan, because some people need to learn to walk again. Some people need to learn to add again. Some people need to learn how to work again. And we want people going back to work. We want them to go back to golfing. We want them to do everything that they wanted to do. Mm-hmm. And you really need somebody who has that kind of knowledge base on what it looks like.
Yeah. And Cheryl, how does your department and your job function tie in with Dr. Doshi and the post-cardiac arrest service?
Well, it's a lot of fun and very interesting in that I work with UPMC pre-hospital care, so I work with a lot of the EMS agencies. So when the PCAST group reaches out to me and says, hey, Cheryl, can we have the EMS, EKG, and the trip sheet information? It's very easy for me to tap into the services and get that information. But like Dr. Doshi said, if an AED is used, whether it's by a bystander or like the police department, we also need to get that information. And how do you get that? So that's what I do for UPMC. I have software programs loaded onto my laptop. I can do the connectivity and get that information and then forward it to the PCAST team because it's a piece of the puzzle that could be really important. Does that person need a pacemaker, an ICD as definitive care so that that doesn't happen again? Or, you know, is it genetic testing, EP testing, you know, different things. And so all of this teamwork from pre-hospital care to in-hospital care, and I kind of help liaison that with getting the information.
So if there'd be one thing, or maybe even two things, that would make your job easier in getting that information for the PCAST group from EMS, what would that be?
Wow. It's already
well,
been done.
That sounds just like a mother. Like when I asked my mom something, she's like, wow.
Well, one thing that's already being done is documenting in the trip sheet. I've seen increased documentation that an AED was used, but who used the AED? Was it a police AED? Was it the church's AED? That's very helpful. Otherwise, I just reach out to the EMS agency and say, whose AED was it? And then sometimes I do detective work and I have to find it. So,
and does it matter what brand of AED was used from your standpoint?
I can take care of it all. And if I don't know, I call technical support for that AED manufacturer and they'll walk me through it.
Great. Dr. Doshi, from an EMS standpoint, is it something EMS needs to reach out to PCAST to let them know, or is it an integrated type system within the UPMC health system?
Yeah, in the UPMC system, we're available 24/7 to any emergency department. So they can always contact us. They contact through MedCall, which is the UPMC system. And we're happy to help with any patient. If they're not in the UPMC system, we can hear about the patient. We're happy to do any of that work, even if that means the patient doesn't come to Presby. For us, this is our passion. We really want to take care of cardiac arrest patients. And, you know, the thing that I think we also forget a little bit in the heat of the moment is we're not taking care of just the patient. You know, we're taking care of the entire community and the family. And if the EMS providers get the names of those people, we can even reach out to those people. Those people have sequela. They saw their loved one die. You know, for us, it's a job. And so we're protected a little bit, but it's not their job that way, you know? And so if we can get the name of the wife, the bystander, the kind of lay person on the street who did CPR that we didn't expect, we can provide those people services.
You know, you're going to find this hard to believe, but our keynote presenter this morning had pictures of his resuscitation with him laying on the floor and his coworkers who did CPR on him until fire arrived 8 minutes later, standing along the wall, and then gone back to them. And his coworkers had PTSD just as much as he did. And how he talked about how that affected them. So, well, you hit the nail on the head there. It's just not about the patient care. It's just not about the patient's recovery. It's a whole concept of care, of family and bystanders and coworkers.
Yeah, we want to really, you know, from a health equity and a healthcare standpoint, if we don't care for that whole community that was affected, we're not doing our job, you know, and it's hard, right? It's hard if you're an EMS provider on the scene running a really tough code. I get that. Small things, just getting their names, seeing if they want to get contacted. We'll do all the heavy lifting afterwards. And, you know, Cheryl's going to be reaching out for the EMS strips anyway, and the AED strips. She can get those names as well. And then we'll do that work and we'll reach out to them. And we'll reach out to you guys too, to the EMS providers, tell you how things went, because I know sometimes it's a little bit of a black box, right? You bring a patient to a hospital, they get transferred, no idea what happened. It comes almost the onus on you to see what happens. And if you ever want to know, contact us anytime. We'll tell you what happened to those patients. Most of those people want to meet their rescuers, not all. One of the other things that Cheryl does is really facilitates those meetings. And if they want to, it's really tends to be very, very meaningful to both.
Yeah, I've had the very fortunate to be part of Cheryl's follow-up meetings with EMS and the family and the survivors, and it's truly so moving. I don't know how you get through some of those speeches without having a crackling voice or a tear running down your eyes, because when we're sitting out there, that's how we feel. So thank you for everything you do with that. Dr. Doshi, for EMS, what if you could give them a couple tips, take-home points for PCAS?
Yeah.
What would that be?
I think the key is keep doing the great work. I mean, that's the first thing. Folks are really working really hard, and we know that our survival in our region is way better than the national. So everything y'all doing is great. Destination matters. Be really thoughtful where you want your patient to go. Remember, they're going to need as much work in the hospital as they did in the field. So be thoughtful about where you want to take those patients, and be thoughtful that they're getting the care that you want them to get. And if they're not, decide where you want them to go and reach out. If you ever have a question for us, we're happy to answer it. This is really our passion. We do this because we love it. We love taking care of cardiac arrest patients. We're really blessed in this region to have great people who do it. So, keep up the great work.
And we're blessed that we have people like you, Dr. Doshi and Cheryl, taking time out of your busy schedules to come up here and meet with 1,000 EMS providers from throughout Pennsylvania. Thank you for your time. Thank you for doing this. And Cheryl, if some EMS providers looking to get in touch with you now, how can they reach you? How can they find you?
Oh, well, they could reach out to you, and you can.
We can do that too.
You're easy to get a hold of. UPMC pre-hospital care, 412-647-5938.
That's perfect. So once again, Cheryl, thank you so much for spending time. Dr. Doshi, thanks for coming up to Summit Springs and EMS Update 2024.
Thank you.
On behalf of the entire EMS Update staff, thank you for joining us. I hope you've had a chance to come out today. If you haven't, we're here until 5 o'clock today. Classes will continue tomorrow from 8 a.m. until 4:30 p.m. This is Brian Shaw at EMS Update. Have a great day.